postoperative complications. Those are our objectives. That's what we're going to go over. Alright, so when we talk about complications, we have to talk about the implications, right? What can we do to ensure patient safety so that complications don't happen, or that we can minimize complications, right? So we have quality assurance and improvement programs within every hospital, every clinic. They're, quality and QI, PI, basically. And then all of you, right, as brand new PAs, you'll be working with your collaborating physician, and they're going to be doing peer reviews. Okay? That basically says that they will look over a certain amount of your charts every month or every quarter and make sure that, they're reviewing your stuff and that it's, they're catching, things that could have gone better or, showing things that you did really well on. And then annual credentialing, every year we have to re-credential or just resubmit saying that, we've done the things that we said we've done. If we haven't done a slit left exam and we don't want to do it, we can take it off of our credentialing at that point, right? So annual credentialing is the thing. In terms of communication, we have a lot of different systems in place, proper handoffs, so warm handoffs, hot handoffs, cold handoffs, there's the real one that you use all the time are the warm handoffs where you're actually going and talking to that provider that you want to hand this patient off to them instead of just it being a consult on paper. Doing timeouts before the procedure starts. Okay, we already talked about that a little bit with our minor procedures. So before anything invasive actually happens, we stop. Everybody in the room stops. You say, this is the right patient, this is the right spot, this is the right procedure, these are the right meds. Okay? Making sure that we're trying to minimize those complications and adverse effects. Okay? And then consent, making sure that the informed consent is done and that they actually understand what they're going to be going through. Standardized communication to subsequent providers, just like I talked about, doing that warm handoff, but it's standardized. Okay? We do a MIS report for an EMS. We do IPASS reports in the hospital. Okay? So it's all standardized so that everybody says the exact same thing, the exact same way, to minimize miscommunication and minimize, adverse effects. Okay? Reporting complications, the morbidity and mortality conferences, or M&M conferences. If you get to go to some in your phase 2, I would highly, highly recommend it. It is very informative. Okay? It basically looks at cases that have already had a complication or already had an adverse side effect, and they go through it from start to finish. Okay? They look at every single step of what happened in that patient's care to see where we could have gone differently to help minimize what happened. Okay? Whether it's we caused a morbidity or that we caused their death. Okay? And then patient satisfaction surveys. Patient feedback is extremely important. We have the ICE complaints in the Navy. I don't know what you guys have in the other services. ICE. Cool. ICE complaints. Okay. You can also get ICE compliments, which is what I got. But the satisfaction surveys are basically making sure that our patient care is satisfied, right? We are still business. We still, as much as I hate that term, we still want to make sure that our product is, what the end user wants. Okay? All right, surgical complications. These are some surgical complications that we'll go over. All right, retained foreign body. This is not just shrapnel. This is not just, stuff that happened during the actual incident. This is stuff that we leave behind in the body, or, whatever. So we have like suture, needles. Okay, the biggest thing is the lap sponges or gauze. But what we have done is all of the blue on the lap sponges and this blue line on the Ratex, all of those are radio opaque. You can actually see here in this other quadrant on the right hand side, that is a sponge left behind. So you don't necessarily see the sponge, but you see the radio opaque line on that sponge. Okay? It's very uncommon nowadays that we leave stuff behind because we have case counts that the surge tech and the circulating nurse do before we ever close, to make sure that everything that we started the case with outside the body is still outside the body. We do have an X-ray wand, or not an X-ray, and then a metal detector wand kind of thing that we put over the body. The nurse does before we leave the room or before we close, just to make sure that everything's out of the body. Okay. But this is a big one. It's a bad one if we do. We don't. Big litigation. We try not to leave anything behind. All right. So when we're talking about the timing of post-operative complications, we have to think of two different timelines. Okay. We have the stuff that happens immediately within the first 2 days, and then we have the more delayed that happens, 2 days to 30 days. Okay? So when we're talking about the first 20 or 48 hours, we're more likely to see respiratory and cardiovascular issues. So failure to maintain ventilation. They, are super overloaded from the fluid we gave during the case, and they're just not being able to keep up with their own ventilation and oxygenation, so they're needing to be ventilated. Okay? There's aspiration, there's sudden cardiac events, meaning MIs, okay, and then hypotension due to hypoperfusion or from us not resuscitating them enough. Okay, those are the main ones, which we'll go over. I think we already went over aspiration, but we'll go over a little bit more today. And then when we think about the delayed, okay, it's what do those sudden things kind of lead to, right? So you have the localized, you have the pneumonia, so if they aspirated during the intubation case, or during the intubation phase of the case, then you can actually lead to pneumonia. If we put a Foley catheter in, they can lead to UTIs. And then systemic, we have SIRS, and then the multi-organ system failure. All right, atelectasis. We already talked about this back in our thoracic days, okay? Remember, it's collapsed alveoli, it's decreased gas exchange. You see a lot with sedentary, people who are immobilized. Causes, pain. So if they have a bunch of rib fractures, or we just cut their belly open from sternum to pubis, it's going to hurt to cough, it's going to hurt to take a deep breath. Okay, so they don't actually breathe normal, they breathe more shallow, so they have hypoventilation, protein secretion, because they can't cough. They're not being able to bring up the crud that's in their lungs. And then low tidal volumes, that shallow breath again, because it hurts to breathe. Okay. Risk factors, smoking, absolutely, or any underlying lung disease, if they have COPD or emphysema or any other underlying lung disease, asthma. Okay. If they're in a prolonged case, okay, if they're under for a long time, this can sometimes cause it, as well as being just uneventful event. Presentation, they're going to present with a low-grade fever, very, very, very common. Okay, like 100, 101. We can't really differentiate between a post-operative fever in terms of, which we'll talk about, but every person kind of comes out of a case, right? We've just done major procedure, their body is being flooded with inflammatory markers, and so their body has that immune response of a little bit of a fever. Okay, post-operative fever on day 1, day 2 is pretty common. So being able to differentiate between just a very normal inflammatory response versus a fever being caused by atelectasis, they're like the same, right? They're the same, 100 to 101. And we just really have to watch them to see if it goes away or if it develops into pneumonia. But there really isn't much we do for that other than a little bit of time off. Decreased breath sounds, vasorales, and then you can see it on chest x-ray. Okay. How do we fix it? Preoperatively, we really try to maximize their pulmonary function. Okay. Send them to PFT if they have underlying lung disease. Really figure out what we can do to optimize their pulmonary function. We really want them to stop smoking at least 2 weeks before pre-op. Okay? A month is really the best, at least quitting smoking within a month, but at least 2 weeks. Post-operatively, so this little, the blue tube device thing here is called an incentive barometer. You should see it on your EMED lab day. This thing is great. So this is a basically an inhalation type of exercise. Okay, we're trying to have them inhalate and take a deep breath. Really opens up those deep alveoli, those basilar alveoli. It's going to precipitate coughing, which they don't like, which then they won't want to take a deep breath, but forces them to open their lungs. Okay, this is not a quick inhale, this is a very long. Think you're trying to pull a milkshake through a tiny straw. Okay, slow, long drag, or driving a television. Good. I won't use that other reference. But yeah, so trying to take that big, deep, slow breath. You're trying to take it as slow as humanly possible to really open up all those basilar alveoli. Okay? Getting them up to walk. That's not always possible. But if we can get them up to walk, that forces them to use more lung capacity, okay, than if they're just sitting on their couch or sitting in their bed. And then pain management. Pain management is huge. Okay, if we are, they can't even take 500 milliliters through their IS, which normal is about 1.5 liters to 2 liters or above. So if we can't even get them to take 500, that's a very, very shallow breath. Okay, they're not able to take that deep cough that they need to. And so doing a multimodal pain control, okay, if it's their lungs that are hurting or the rib cage that are hurting or their belly, we can do blocks. We can do a patient-controlled anesthesia device. That's the button, the PCAs. Okay. We can also make sure that they're on, like I said, a Tylenol, Motrin, muscle relaxer. We can do Letoderm patches. Okay, there's a lot of other multimodal things that we can do along with narcotics if needed. Okay. How do we treat atelectasis? It's really going to be chest physiotherapy using the IS, percussion and or postural drainage. We can do, if they're pretty sedentary and they're immobilized, we can do some mesotracheal suctioning. Okay, and then we can, if we really need to do a therapeutic bronchoscopy, and go in there and kind of suck out a lot of the mucus that's been settled there to hopefully open those lungs back up. All right, that leads to pneumonia. Okay, the presentation of pneumonia. We've already seen this: fever, tachycardia, productive cough. Okay, you're gonna have rales and diminished breath sounds bilaterally. Or, okay, could be one-sided. Most likely it's going to be bilateral, but could be one-sided. On the chest X-ray, if it's an early pneumonia, it's more of an infiltrate. If it's a later, it's going to be more of a consolidation. Okay. How do we treat it? We give it antibiotics. Okay. We try to get them off intubation if as soon as possible. So we want aggressive pulmonary toilet. They may be doing what we call the pulmonary vest, which is a vest that PT or RT will put on them, and it actually has vibrations. So it's trying to break up all those vibrations to get it out. Now, if they are not intubated yet and they are close to failure, meaning we can't maintain their PCO2 between 35 and 45, we can't maintain their oxygen saturation above 95%, we're most likely going to intubate them and put them on a mechanical vent. Okay. Alright. Moving on to ventilator-associated pneumonia. You have to have been on a ventilator. Get ventilator-associated pneumonia. Okay. This is the being on a ventilator, though, is the single greatest risk factor of getting VAP. Make sense? So normally, if you've been on a ventilator for 5 to 15 days, that is the peak and plateau. Okay. Of getting VAP. After 15 days, it really significantly declines in the rate of VAP. But that's why around, if you've been intubated for about 2 weeks, we go and do a trach, which is helps decrease the amount of cross-contamination between mouth bacteria and the lungs. Okay. How can we sometimes prevent that? Sometimes we can't, but sometimes we can elevate the head of the bed if we can. Post-pyloric feeding, so if we can do a Dobhoff that goes past the pylorus, okay, because if we're just feeding the stomach and it doesn't actually move around, they can actually aspirate and cause VAPS. But if we can do post-pyloric feeding, we can do ventilator liberation trials or spontaneous breathing trials. Okay, we do it every day. Okay, if you ever get to round in the ICU, the mornings get a little rowdy because we turn off all the sedation room by room, and we see how they breathe on their own. Sometimes it goes fine and they breathe on their own, other times it doesn't, there's turn on their sedation, other times they get very anxious and very mad that they're intubated and they try to extubate themselves but they're not ready. Okay, so it's very rowdy in the morning in the ICU. But we have to do that. We have to let their lungs and their body try. Right? So we lower their sedation enough that they're awake. Okay? And we can try to get them to breathe on their own. If they're healthy enough, if they're past the most critical point, most of the time they can start breathing on their own. And then there's different calculations within the critical care world that we have to get to in order to see if they're going to successfully stay extubated, or if their risk of re-intubation is too high, we leave them to practice another day. Minimizing oversedation is really key, okay? Like there are some nurses out there who really want everybody to be asleep and don't move. That's not how good medicine is, right? We want a good, calm patient, but an awake patient. Okay? It's okay to be awake and intubated. It happens all the time. Okay? But we want them calm. And then really doing an aggressive oral hygiene. Okay? Don't brush your teeth for a day and then, or even 2, and really tell me if you would want your patient to have to deal with that. Okay, so we at least every shift or more, depending on their oral health, we'll have the nurses actually brush their teeth and do oral hygiene to really help prevent that oral bacteria dripping into their lungs. All right, aspiration pneumonia most likely causes from vomiting, most likely from induction of anesthesia. Okay, we can also get it from narcotics. If they have an ileus bowel obstruction, meal prior to surgery, we can't always prevent this, right? If they're trauma and they just came from dinner and they're bleeding out, we're going to take them to surgery either way, so we have to prepare for that. If they're an obese or pregnant person, increased intra-abdominal pressure can sometimes, during that induction of anesthesia, just have them vomit, okay? And then ultraventricular status, if they aren't able to protect their own airway from that vomit and they're super drunk, super high, they can't protect their own airway, okay? So how do we prevent it? We try to make them MPO for 6 hours prior to surgery if it is an elective or urgent surgery, okay? That does not count for emergent surgeries, okay? We can fix their lungs later if they aspirate. We can't fix it if they're already dead. Okay. We can also do NG decompression, so as soon as we intubate them and they're asleep, we can actually drop an NG tube down and try to suck out all of the fluid that they just ate. Okay. And then another thing is like that cricoid pressure, okay? Pressing down on the trachea to close off the esophagus and bring the vocal cords down into view. It's a twofold, right? It brings the vocal cords down, but it does close off that esophagus, trying to prevent that vomiting from going into the lungs. Okay? We manage it. If they vomit during intubation, right, we try to suction immediately. As soon as we can, we do a bronchoscopy. Okay? Try to suck out as much of the food material out of their lungs as we possibly can. Okay? We'll irrigate as much as we can. Okay? We'll do bronchial hygiene, which is basically doing more suctioning during the first couple days after the surgery. If we won't prophylactically put them on antibiotics, Okay? But if they start to develop fevers above 101, they start to have other symptoms of pneumonia, okay, we will then put them on antibiotics. If they are, say they're extubated post-case, but then they start leading into the respiratory failure realm, we will just re-intubate them and put them back on it until their lungs heal enough that they can breathe on their own. Alright, pulmonary edema causes volume overload. Okay, we did it. They put too much volume into their system, cause their heart to not work efficiently, or they're already in congestive heart failure and we were not judicious with our fluids. Okay, or if they're in renal failure, those are the three main causes of pulmonary edema. It's not the only three causes, okay, but those are the three main ones that I want you to know. Management, we really want to have close judicial fluid administration. Okay, we are not just giving fluid to give fluid. We went over this in the first block of that maintenance, or if we're replacing versus resuscitation. Okay, really need to have good judicious fluid administration. Okay, sitting them up, getting them up out of the bed and into a chair as early as possible. We can use diuretics in certain cases, okay, to try to pull off as much fluid as we can quickly. Okay, we still have to rule out PE and MI. That is going to be a running theme across this entire presentation today, this entire lecture, right? We still have to consider and rule out a PE and MI post-surgery. Okay, don't be the one to miss those. If we're starting to see more respiratory failure, we can try BiPAP, we can try CPAP. If those fail, we can go then, we have a low threshold to reintubate them and put them on a vent to try to help them through this. Okay? Alright, moving on then to acute respiratory distress syndrome, or ARDS. Okay, this is a non-cardiogenic pulmonary edema. This is an inflammatory response. Okay, this is not because of how much fluid we gave or because they're already in congestive heart failure. This is an inflammatory response. Okay, it resembles pulmonary edema, but it does not respond to diuretics. Alright, so the two main things are if your alveoli are open, fluid fills them, or you have atelectasis. So both of those combined lead to very poor perfusion. Okay, how do we treat this? We put them on a mechanical vent with a decent end expiratory pressure, or peak. Okay, we want to get those alveoli to open up to try to have that gas exchange on the entire surface of the alveoli. So we'll increase their PEEP enough to have that increased pressure at the base, or at the end of their lungs, okay, to try to either push that fluid out or have a better chance of having that surface area to do that exchange. Okay, ours is really hard to treat. All right, you guys have seen this before? Yes? Okay, I want you to know it. Okay? So, normal lung volume for a person between 3 and 4 liters. Okay? When you take just your normal breath, you're staying around there with that as your tidal volume. Your normal breath is your tidal volume. Okay? When you have a deep inhalation, that's when you get into your inspiratory reserve volume. Okay? And then when you exhale as far out as you possibly can, you're draining your lungs as much as you can, that's your expiratory reserve volume. And then everything else, okay? You have to remember there's still that residual volume, okay? Even after you have exhaled everything you possibly think you can, right? There's still air in your trachea, there's still air in your bronchi, there's still air in your alveoli. That is your reserve or residual volume that never goes away. If it did, your lungs would collapse. Okay? So then when you're talking about your functional residual capacity, that is everything that is after your normal exhalation to the very, very end when your lungs are collapsed completely into, shriveled raisins. Okay? When you're talking about inspiratory capacity, that is your normal breath plus as much air as you possibly can. So it's everything. Vital capacity, again, from the biggest breath you can until the lowest you can breathe out. And then the total lung capacity is really, really important because you have to add all of that up. Okay, when we're trying to decide on, what or how much fluid to give them in their ventilator, or how much air to give them in their ventilator, we really want to know like their tidal volume compared to their inspiratory capacity, their expiratory capacity, as well as the total volume that we can actually give them. Okay, because my volume is going to be different than say his volume. Right? The smaller you are, the less volume you need. The bigger and taller you are, the more volume you need. So that's very important. It doesn't just fit everybody. It's not one size fits all. Okay. So, criteria for respiratory failure. Okay. If you have someone who is tachypneic, okay, 25 to 30 or above. You have someone who's taking very, very shallow breaths. Their total lung volumes are less than 4 milliliters per kilogram. Okay, that's not that much. That's like 500 or below. Okay, if they're hypercapnia, so their pH-CO2 is over than 45, or their pH-O2, so they're hypoxic, is less than 60. Increased use of accessory muscles, so they're using a lot of their intercostal muscles, or their paradoxical breathing, okay, belly breathing. Those are signs of impending respiratory failure. At this point, you should be getting the vent ready, or they should already be engaged. Okay? So routine ventilator, before we get into like ARNs and treating all that, but routine ventilator settings, okay? There are many, many, many different types of modes. Okay? This is basically how you are setting the ventilator to actually work. Okay? So the most common one is ACDC. Meaning assist control, volume control. Okay? What does that mean? It means that there we set the rate, let's say we set the respiratory rate of 12, so every 6 seconds the ventilator is going to give them a breath. But the patient can trigger a breath. It then will assist them with the amount of volume that we have set. Okay? So if they're not breathing on their own, it'll still breathe for them. But if the patient wants to try initiating a breath, the machine will then force that amount of volume that we've set to actually have that be an efficient breath. But they can still initiate it if the patient's body wants to. That is assist control, ACDC. Okay? When we talk about tidal volumes, okay, we really want to know their ideal body weight, not their actual body weight. Okay? And there are charts for that, but you do that and then that is their kilogram, their ideal body weight in kilograms, and we want 6 to 8 milliliters per that ideal weight kilogram. Okay? So normally it's going to be a lot lower than what you guys think. Okay? It might only be, 400, 500, maybe only 300, okay, because it's against their ideal body weight and not their actual body weight. Respiratory rate, we want normally between 12 and 16. We normally start with a PEEP of 5. We can go up to 10. Normally though, we start at 5. Okay, and what that is that that's the pressure that is constant on the system to keep those alveoli open. FiO2, we start at 100%, so they're on 100% oxygen. Okay, and then we titrate pretty quickly, okay, down to at least an oxygen saturation of above 92. So normally we let them no lower than 40% FiO2 while they're ventilated. Okay, unless they're on spontaneous breathing, then we can potentially drop it down to 21% because that's normal room air. But normally we don't drop below 40. But a lot of times we'll try to get them to hover around 60% FiO2 while on a ventilator, okay? Not everybody's going to be able to do that, but we always start at 100 and then titrate down so that we're not over-oxygenating them, because research has shown that just 100% oxygen all the time for days can actually be damaging to cells. Okay? And then another one is inspiratory to expiratory ratio. Okay, we want, you know, if this is in seconds, 1 second of inspiration, 3 seconds of expiration. Okay? This is the normal E to IE ratio. Okay? It will change depending on if the pathology of the lung changes, which we'll see. Okay? But this is the normal. These are the normal settings that you'll see if you have to initiate somebody in the ER. Okay? So when we talk about ARDS, okay, you have edema of the lungs, that's inflammatory. Okay, there's a lot of fluid in the lungs, there's a lot of resistance of the lungs. How are we going to get through that? Because it's not necessarily going to work on just a normal ventilator setting, right? So we want the peak to actually be higher. We're trying to reopen those alveoli. So the peak may be between 10 and 15. Okay? Anything above 15 is really high and you really risk various trauma. Okay? So most likely, is that the fire alarm? It's not in our room, so hopefully. Okay. So, yeah, so we really don't want a peak greater than 15. We'll normally start around 10 and see if we do get there. Okay? Tidal volumes, though, are lower. We're actually not giving them as much of their tidal volume. Okay? We want them to take a little bit shallower breaths with that higher peak. Okay? So that we're only going to go between 4 and 6 milliliters for their ideal body weight acceleration. We want to maintain their FiO2 of about 60. Okay, the lowest we'll ever go is 40. That may be different with cardiovascular surgeons and cardiovascular patients. They have a whole different set of rules. I don't follow them, so if you're NCT, you're like, that's not what you said. Don't quote me, okay? But these are for surgery and medical ICU patients, not cardiovascular. All right, here's the biggest change. Right? We want to increase their expiration time. Okay? So their I to E ratio will be 1 to 4. Taking a deep a breath in and then letting it exhale over 4 seconds. Really trying to draw out that breath. Okay? We can prone them, which is what you see in the picture. Okay? The patient's actually on their belly. Allows the aeration of the lungs to use different parts throughout the day. They're not going to stay prone. They'll probably do 8 hours prone and then 16 hours on their back. Okay, or 12 and 12. It really just depends. We have really cool beds called roto beds that'll, strap them in and then flip them. Hard to come by though. Sometimes they're really expensive. And then, so the APRV. So the airway pressure relief ventilation, that is a ventilator mode, APRV. Okay, that is the mode that we will most likely use in an ARDS patient. It has it allows for a lower vital tidal volume, has shorter bursts of breath, okay, with low amplitude but frequent, rapid VT-max. So it's actually almost causes a vibration, trying to break up that fluid in their lungs. Okay, APRV, if you ever see somebody on APRV, it looks like they're kind of shaking. That's just the way that the ventilator is making them look. Okay, it is a normal ventilator mode, but we only really use it on certain people. So for like ARDS or inhalation burn victims, okay, where we're really trying to break up or get rid of fluid in their lungs. So those are the differences. All right, any questions on airway stuff? Lovely. Okay. Do you guys want to take a break? Oh no, when did it start?
9:10.
9? Okay, so we can go for a little while. Okay, central lines. Central lines are great. I love central lines. Okay, we place them into larger vessels. because peripheries don't like TPN, some antibiotics and blood products. It'll handle it, but not for a very long time. So we use central lines, which were our places for central lines. So IJ, subclavicular, subclavicular, and then femoral. Okay. Those are big bore tubes on the bigger vessels. Okay. So we use this for more caustic substances to monitor hemodynamics. The Vigileo we talked about in our thoracic lecture. Okay. Swan-Ganz catheter, you'll really only see that in CT surgery nowadays. I've never used it, I've never seen it. Okay, it's just not a thing in surgery anymore with the Vigileos that we have. You get the same thing without all the complications that Swan-Ganz have. And we can leave it in for a lot longer compared to the peripheral IVs. Okay, because it's in a bigger vessel, it has less likely chance of collapsing. Okay, so we can have better blood draws on it and better access. Okay, if it is a triple lumen, okay, we can actually instill 3 things at one time. If it is just a cordis, a single lumen, then we have the ability to input a lot very, very quickly. Okay, so when you're in the trauma bay, we're most likely, well, we are going to be using a cordis, a single lumen, either in the subclavian or the femoral, okay, because we want to try to get as much blood into them as humanly possible. We can pretty much, if it's a cordis in the fem, we can get about a unit of blood within 30 seconds. Okay, very, very fast. Okay, but if you're doing an IJ or a subclavian PTX, so pneumothoraces are the most common, so what do you have to do after you place it? Chest x-ray, right? Anytime you place lines here, right, you have to do a chest x-ray to make sure that you didn't drop the lung. Arterial injuries is probably the next most common, okay? If you poke it a lot of times, or if you don't get through all 3 layers of the vessel and you only go through some and you dissect, part of that layer, okay, you can cause pseudoaneurysms. If they're already in a hypercoagulable state, you'll have to continue bleeding around that site, okay? And then if it kind of thrombosis around it or within it, because it's been in for a little bit long, then we can cause strokes. Cardiac tamponade, less common, but pretty devastating when it happens. And then infection. Okay, infection is for a long-term one. So if you're thinking chronic use of central lines, infection is probably the highest, most common. Okay, but you have to remember when we're doing trauma, we're not really worried about infection control at that point. Okay, we wave them off a little bit, but we're not bound up. We're not doing it on a drill. Our point there is trying to get fluid into them as quickly as possible. We'll fix the bacteremia that we cause later, and give them antibiotics later. Okay, so a lot of times we'll call those dirty lines. And once they get stabilized, we'll put new ones in under sterile procedures, and then we take those out. Okay. So, all right. Fat emboli associated with long bone or pelvic fractures. Okay. Basically, the fat lobules from the marrow migrate into the pulmonary capillary beds. So it's basically like a PE, but by fat. Doesn't really break up with PPA. So we try to not do this. We try not to allow this. Normally we see these within 12 to 72 hours after the injury. You'll start presenting with respiratory insufficiency, neurologic changes, confusion, obtunded comas, petechiae in the area. Okay. What do? We try to do just supportive care. Okay. Doesn't say enough. We could potentially try doing an embolectomy. But we really just do higher peaks of positive and expiratory pressure ventilation, so higher peak ventilation like ARDS. We give them diuretics. Okay. We try to monitor their EVGs, so they'll most likely have an ART line. We're still going to rule out that MI and like an actual clotted PE. And then the biggest thing, how do we prevent this, is early fracture management. Okay, if we can get them into the OR and do an external fixation or an ORIF to try to close up that space, the less likely that marrow has a chance to move. Deep vein thromboses, all of you remember Virchow's triad. Where you have hemostasis, okay, you have an endothelial injury, and then they're hypercoagulable. Okay, so they're already at risk of clots, they're already, they're already in stasis, they have that injury. Okay, risk factors, major trauma, if they're malignant or have cancers, okay, age over 40, they're pregnant, really important. Postpartum or OCP use, okay, OCP use usually goes up if you smoke. So you get double whammy, okay? They've ever had a prior DVT, okay? And then prolonged immobility. So if they, again, asking whether they've done any recent travel, either by air, bus, long car ride, doesn't matter, they're sitting for long periods of time, okay? What we see these in surgery patients are those people who are on bed rest post-op. Okay, we don't want them getting out of bed. They have pelvic or lower extremity surgery, major general surgery, or if they have a central line present. Okay. How do they present? Their leg gets swollen, warm. They'll have sapidity edema. They'll have that Homan sign. What's the Homan sign? Anybody heard it? Yep, so pain with passive dorsiflexion. Okay. Alright, so what are we going to do? Obviously we do the H&P, we do imaging. Duplex ultrasound is the #1 image that we want. You can do a venogram, a duplex, ultrasounds will find it the good majority of the time. Okay, how do we prevent it? Stockings. Okay, depression. We can do SCDs, okay, sequential depression devices. Everybody who is a surgery patient will get these ordered on admission. And then getting them out of bed and walking is the best. Okay, early ambulation is the best. Okay, say they weren't able to get out of bed and they actually developed a DVT. What are we going to do? We're going to anticoagulate them if we can. Okay. If they have no other contraindications, we'll anticoagulate them. We'll most likely do either sub-Q or subcutaneous heparin, which is 5,000 units 3 times a day, or we'll do low molecular weight heparin, which is enoxaparin or Lovenox, and that is, depending on weight, either 30 milligrams twice a day or 40 once a day. Those are inpatient. Now, say they have a contraindication, they have a head bleed, they just got done with major surgery, and we're really worried about them bleeding. Okay, we can either start them on an IV heparin drip. So it's not sub-Q, it's actually in their system. It's a drip. If they start to bleed, or we see any signs of neurological changes, we can stop that drip and it stops the effects pretty quickly. We also have what's called a IVC filter. We can, if there's no way that we can put them on an anticoagulation at the time, we'll have IR or vascular place a filter. It's like a little upside down bird cage that sits in their IVC, and it's supposed to help catch clots before they go up. Okay. Now, once they are ready for discharge, that's when we start getting them ready and transitioning onto an anti-10A or warfarin or Coumadin or any of the longer term ones. Okay. All right. Pulmonary embolisms. Multiple emboli, lower lobes are more common. Okay. If you hear the term saddle embolus, it means that this clot spans both bronchus or spans both pulmonary arteries. Okay, saddle, think of it as being across both. Saddle emboli are the worst. They're the number one killers. Think of it as like a silent, you know, I don't know what they call it in cards, the widowmaker, right? Okay. If it's acute, you're going to get symptoms immediately. Okay. If it's subacute, meaning they start to develop symptoms, it's lower, it's like in the subsegmental branches of the alveoli, like it's not in the main bronchi. Okay, you're going to have symptoms develop over days. Okay, and then chronic, if we don't ever do anything about it, and they still live, they're going to develop pulmonary hypertension because they're trying to work around those clots. Okay. What are the risk factors? Malignancy, pregnancy, immobilization, nephrotic syndrome, okay, and blood dysphasias, meaning the hypercoagulable states affect Pegleiten, those kinds of things. How are they going to present? They're going to present being hypoxic. They're going to be tachycardic. They're going to be tachypnic. And they're going to show signs of DVT. They may actually just come in cardiopulmonary arrest. Okay. If it's a saddle, they may just come in cardiopulmonary arrest. Okay. There's multitude of tests that we can do to heighten suspicion. Okay. There's 3 screening scores that we use. So say they're coming in and they're in an acute phase, but they're stable, right? Wells score is the most common scoring system that we use. The other 2 are used, but not as common. Okay. So if they have symptoms of the DVT, there's no other diagnosis to explain the symptoms, they're tachycardic, they've been immobilized for more than 3 days, or surgery in the past month, they've ever had a prior DVT or PE, they are coughing up blood, or they have malignancy, they have 6 or more of those things, then high probability that it's a PE. All right. What are you asking about on history and physical? Any blood disorders, cancers, immobility? Okay, you're asking if they're dyspneic, if they have any chest pain, if they have any hemoptysis. Okay. Vital signs, if their saturation, their SaO2, right, is less than 95% of presentation, it's the worst prognosis. They may be hypoxic, they may be hypocarbic. Some of you have heard my soapbox on D-dimer. You really only order D-dimer if you are absolutely almost 99.999% positive it's a D. Okay? Or no, other way around. If you do think that it's 99.9, you don't necessarily need to do D-dimer. Okay? You want to do a D-dimer when you really don't think it's a DVT. Okay? And why? It's because if it's negative, you can rule DVT out. Okay? If it's negative, you can rule it out. But if it's positive, there's a lot of other shit that you have to do. Okay? So if you already think that it's a DVT, you already have a proven DVT on ultrasound, you don't have to do a D-dimer. Okay, it's going to be positive, and then you're going to have to do a lot of other stuff that I'm not going to go over, a lot of other stuff, because D-dimer is not sensitive to DVT, but it is specific. Okay, so it'll have a very high positive negative, right? Like a high negative. That makes sense? Like it's very, like if it's negative, it's not DVT. But if it's positive, it could be other things. That make sense?
Sensitive, not specific.
Did I flip those?
I think so.
Okay. Easy break. It's not on the slide, so I can't really test you on it. Okay? But the D-dimer will be elevated, so you really don't need to do it if you think that you have a high probability of having a DVT. Okay? You want to do the cardiac enzymes, and you'd want to do the BNP. Okay? Again, you want to rule out that MI and CHF. You want to do the EKGs. Okay? 70% of the EKGs will show the changes that a PE shows. Okay, they may have new onset AFib or right bundle branch. And then 30% will have that S1Q3T3 presentation. Imaging, you still want to do chest x-ray, but it's limited. The test of choice is that spiral CT chest with PE protocol. Okay, they get contrast loads in different points, so that they do like a non-con first, and then they possibly would do a contrast study. Okay, if we cannot give contrast due to pregnancy and or renal function, we can do nuclear radio nuclear study, the BQ scan. Okay, looking for that BQ mismatch. And then last line is the pulmonary angiography, which will be done by IR or vascular. Okay. If we are already at the spot of doing an angiogram, it's both diagnostic and therapeutic. Okay, because if they see something, they can do something about it right then and there, versus all the other things. And if you see something, then you have to get these people involved to do an angiography. Okay. All right. So say we're not going to angiography, how do we actually treat this? We want to supplement with O2. We want to have that IV access. Okay, we're going to do sub-Q low molecular heparin. Okay, again, if you're thinking bleeding is going to be a concern, we do the IV heparin drip. They're going to be on warfarin for 3 to 6 months. Okay, we want that therapeutic INR between 2 and 3. We could theoretically change over to a 10A or direct arm inhibitor. Rivaroxaban or Apixaban, okay? Those are our two most common ones. The other ones, I think I've done, so I don't think I've done either one. So I think I do Apixaban and we're most often, okay? Because we don't have to do INR checks, right? They're not great to be reversed, like warfarin. There are some reversals. It's stupid expensive. If we have to reverse it. Like I think one vial for Apixaban is anywhere between $10,000 and $35,000. Okay, we may have to do that multiple times. Okay, so stupid expensive for reversal. But if they're not at risk of falling and they're going to be on this for a while and they don't want to have to be tied to a Coumadin clinic, then this is a good choice. And then again, the IVC filter for people who can't be on any anticoagulation. At the time? Okay, so we'll finish here for a 10-minute break. So the IVC filter, like I said, is distal in the IVC, and for people who can't take any anticoagulation. Okay, let's come back at 10:20. So moving back into complications post-op. Okay. We're going to move into more cardiac complications. The most common one is atrial fibrillation. Okay, we put a lot of people into AFib, more than we like to admit. Okay, we still have to rule out MI and PE first because they present with tachycardia. But you get the EKG, you do the enzymes. Okay, you want to check electrolytes, make sure that the potassium and magnesium are in check. And then make sure they're not fluid overloaded. Most of the time they are. And we put in just enough strain on their heart to, throw them into AFib. So we want to do rate control, we'll do a beta blocker and fix the electrolytes. They give them probably a diuretic. We normally don't shock AFib unless they're being unstable in this sense, okay? Because they're inpatient, they are in a post-op period. Most of the time they have not had enough time to really cause any emboli within their atrium. So we'll try to get this medically managed first. But if they're unstable, ACLS rules, okay? And then we shock. Hypertension, hypotension, those are probably our next two most common. Hypotension probably being the first out of the two. Okay. We want to check fluid statuses, and we want to make sure that they're not in a sort of shock, right? Cardiogenic, neurogenic, or distributive. And then fix it according to what is actually going on. Okay. Gastroenterology complaints, we have seen all of these within our last block, so none of this should be new. Okay, and ileus, most likely from hypovolemia and or abdominal surgery. We can mitigate this by giving them pre and post-op Entered. Okay, we put them on an ERAS or ERAS protocol, which we talked about a little bit before, and this just helps keep things moving. Okay. GI bleeding, mitigating that with PPIs, lesion blockers for high stress states. We want to just try to prevent those ulcers from forming. Anastomotic leaks, sometimes we can't get away from those, but it's something that we have to look out for. If it does leak, we can go back to the OR. Depending on if they're stable or not. Most of the time we will also leave drains around these anastomotic spots, so that if it does leak, we have a way of trying to collect that leak, that fluid, before it wreaks havoc other places. Okay. Jaundice, if they're liver failure, they're malnourished, if we give them a medication that hurts their liver, we have to watch for those. Less common, but it can happen. In our critically ill patients, the acopulous cholecystitis, again, we already talked about that. No stones, but their gallbladder pissed off. Okay, because they're in a high stress environment, they're critically ill. And then pancreatitis, we see this again, most likely after ERCPs, biliary surgery, and or frequent medications. All right. Something you probably have not thought about since, what, ClinLab? Maybe? C. diff. The lovely C. diff. Clostridium difficile. Okay, it causes a pseudomembranous colitis. Okay. Antibiotic-associated diarrhea. The three biggest offenders, clindamycin, cephalosporins, or quinolones. Okay, those antibiotics, especially if given over long periods of time, will really disrupt the normal flora of the gut and cause this bug to just thrive. Okay. It is a spore. Okay, so the best way to prevent it is through hand washing. This is not something that you can use just Purell for. You really have to have a hand washing. Okay. So when you suspect it, if you have a patient, inpatient or outpatient, who has the very foul-smelling, very loose, neon green stools, and they have to be more than 3 times in 24 hours. Okay? They have to have had a history of being on an antibiotic. We have them do stool samples. Okay? We treat this with oral vancomycin. IV does not cross over into the gut, so it has to be oral vancomycin. We can do metronidazole as well, or clindamycin, but most likely it's going to be oral vanc and lead. Okay? If those do not work, we do have some drastic measures we can take. We can do fecal transplants. Okay? Sterile poop. We put transplant into them. I've actually never seen it, but it is a fascinating thing. Or we can just take their colon out completely, either completely or the offending part, take a subtotalectomy. But again, hand washing is the #1 way to prevent this. When you have somebody on C. diff precautions, you go in your room with a gown, gloves, mask. Okay, you may even have face shield pending on the hospital, but at least a gown and gloves. Okay, we want to do judicial use of antibiotics. We're not just throwing antibiotics and we take them off as soon as we possibly can. Okay, avoiding those contact precautions. And then this is why it's kind of rampant in the critical care patients, because we're trying to prevent ulcers, but also giving those gastric acid suppressions can actually cause this to flourish. So finding that happy medium balance, sometimes we just can't get away from using those PPIs, and so the risk of getting C. diff is higher. Okay. Moving on to renal. oliguria. Okay, we have the pre-renal, intrarenal, post-renal. Again, I don't think any of this is something that you have never seen before. Right? Pre-renal dehydration, hypovolemia. We have to consider this person or post-op patients. Okay, we just didn't resuscitate them enough. Their kidneys took a hit, most likely causing an acute kidney injury. Okay, you take post-op day 1, you check their BMP, and it's 2, and the day previous it was 1. Okay, so we put them on a little bit extra fluids that day. Okay. If they're not hypovolemic and they have good urine output, then we have to think, is it intrarenal or post-renal? We have to think intrarenal if we've given something that would offend the actual parenchyma of like some sort of neurotoxic drug. Okay, contrast, antibiotics, diuretics. We want to compare that pre and post-op BUN and creatinine. But we also see this with crush and electrical injuries. So myoglobin, okay, is the breakdown of heme and muscle, and it really clogs up. We see this a lot with rhabdo as well. Okay, clogs up those kidneys, so it's not able to filter as much. Think of like the myoglobins as like the fluid in with atelectasis or with edema, right? It's just not allowing the glomerulus to really filter out what it needs to filter out because it's all clogged with these myoglobins. Okay? So we give them more fluids to flush out your kidneys. Post-renal, okay, this is an obstruction. Okay, do they have prostate hypertrophy? Do we need it? Should we not have taken them off of their alpha blocker for their BPH? Do we need to put them back on it? Okay, obstructed bladder catheter. I've seen this a lot in trauma with bladder injuries. Okay, you have clots that clog up the Foley catheters. We have to do continuous irrigation or figure out why that catheter is not. You may have to actually take it out, put a new one in. Urethral injuries. Okay, again, I see this a lot in trauma. We do the retrourethrograms. Okay, we do CTs, trying to see if there's any trauma to that urethra, causing that urine to not be able to exit the body. And then we see a lot of this neurogenic bladder with either spinal cord injuries or the elderly. Okay, especially diabetics. Okay, if their bladder is not receiving the signal in order to pee, they're going to end up with urinary retention, and then it's going to look like an obstructive type of process. Okay, but their bladder, if there's nothing actually blocking it, it's just their bladder isn't getting that signal to release. Okay, we see this a lot with constipation, narcotic use, antihistamines in elderly. This is the leader, right? You have someone who's been taking Benadryl for days because they can't sleep, and they're like old. They'll come in with urinary retention. They're like, I can't pee. I'm like, stop taking Benadryl. Okay. So antihistamines is a big cause of a pseudo-neurogenic bladder. Okay. So how do we try to prevent it? We try to get them to void prior to going to the surgery if they can. Okay. If they're going to do a abdominal perineal resection, we'll try to leave that catheter. Okay. Inguinal hernias with BPH, we try to treat the BPH prior to doing the inguinal hernia repair. And then the treatment for acute urinary retention is putting a bully. You know, just put in a bully or doing a straight path. Presence of 1,000 milliliters or 1 liter of urine in the bladder. That's a little high. That is the book answer. That's a little high for like actual clinical practice. I say it's normally anything greater than 350. That's a Coke can. Right. Let's see. How many is this? This is 473 milliliters. Right? That's not that much, but like it is. Your bladder is not that big. It can get big, but we try not to. We try not to like a liter, right? Is a lot of urine. That's going to be very uncomfortable. So if we have somebody who's at risk for neurogenic bladder or an obstruction, we try not to let it get to a liter. A liter is very painful So we normally say anywhere, like if they consistently have, like they've tried to pee or their post-void residual is still greater than 350, we'll put them on a catheter for 20 to 48 hours. UTIs. So after bladder catheterization, right, always, you have to think of always the complications. So UTIs are the most common. We try to prevent this by doing sterile techniques. We try to do daily Foley care, okay? And we remove it as soon as humanly possible. As soon as they're able to like function and use a urinal or get up and go to the bathroom and use bedpan, we try to remove this fully as soon as possible. And it can't always be the case, but we try. Okay? Urethral trauma. This is something I see a lot in people who are like ICU delirium or they have dementia at baseline. They, feel a tube coming out of their penis or out of their, urethra, and they just pull. Yeah, right? And the balloon is still inflated. So that is a lot of trauma going through that urethra. Okay? People who have BPH. Okay? I've had to actually call urology to come down and place a Foley over a wire because their BPH was so bad. But they were having urinary retention and needed a Foley. Okay? And then phimosis and paraphimosis. I don't see this as much, but it is a risk. Okay? And definitive treatment is just circumcision. Okay? All right, neurological complications. This is a lot to do with not necessarily their injury, but how we place them on the table. Are we padding correctly? Are we stretching nerves? Okay? Are we putting pressure on a nerve throughout their case? Okay? When it's a direct injury, those are the four most common. Okay? So if we are doing a hernia repair in ilioinguinal nerve, if it's open, we most likely will cut it anyway. Okay, we'll have that conversation, and it's just going to have a little skin numbness versus prolonged pain. Chronic pain, mastectomy. We really watch for that long thoracic nerve like we talked about, so we don't cause that wing scapula. When we're in the thyroid, parathyroid realm, we're looking for that recurrent laryngeal nerve, which can cause hoarseness or dysfunction of the vocal cords. And then when we're doing carotid endarterectomies, we have the hypoglossal nerve right there. That'll, if we cut that, you'll have a deviated tongue. You may have some speech impediments. You may have some swallowing issues. Okay, so those are the four that we really try to watch out for. Okay. And then mental status change. So ICU delirium is a thing. Okay, we try to have a nice sleep-wake balance. Okay, we try to have the windows open during the day, the TV on, the lights on. At night, the lights off, the TV's off. They try to sleep when they're supposed to sleep, be awake when they're supposed to be awake, which is why we try not to overstate, because if we can keep that wake-sleep cycle correct, it really limits the amount of ICU delirium that we see. Okay? But we can't just chalk it up to ICU delirium. We have to make sure that they're not hypoxic, that they're not having a hypovolemic event, that they're not starting into sepsis, that we're not giving them a medication that is really screwing with their, all their thoughts, okay? And then we have to rule out strokes. Okay. ICU delirium or any sort of hospital delirium, you really must rule out these things first before you can just say, well, maybe it's just that. God damn it. Hold on, I just broke the trigger. Okay, moving on into hematological conditions or complications. Alright, so hemorrhage from anticoagulation, okay? HIT or heparin-induced thrombocytopenia is a very big real thing that we deal with. It's if we think it's HIT, there's a HIT algorithm looking for, checking their anti-10A to see if that's truly the case, okay? If we can't change it from heparin, we try to take them off heparin as soon as possible if we suspect HIT. but sometimes we have to wait for those labs to come back because them stroking out from a clot versus mitigating their thrombocytopenia, we have to rule those, risk versus benefits. Okay. PIC, or disseminated intravascular coagulopathy. Okay, this is a killer. If they go down into the spiral, it is very, very, very hard to correct. Okay, normally they start off with a prothalamic condition. They are hypercoagulable. Okay, and then you have multiple thrombus. You go into multi-organ system dysfunction or failure. Okay, it then progresses to your body consuming all of your coagulation proteins. Okay, basically it overcorrects, and your body just takes up all of your clotting factors. And then you then spiral into this, well, now I can't clot, and now I'm in just a bleeding. I'm just bleeding from every orifice. Okay, severe bleeding. We treat this with fresh frozen plasma. We try to correct it to replacement of the coagulation factors. Okay, but once they get down to like that severe bleeding, it is very, very difficult to treat. Moving on to transfusion reactions. Okay, hypocalcemia is the most common, but we have anything over like 6 units of packed red or whole blood. Okay, the citrate in the banked blood can really cause a hypocalcemia. Okay, so once we get to a certain number, we just start prophylactically giving them calcium to try to prevent this. Transfusion reactions, so they can be feverish, they can have move into what's called a trolley or transfusion-related acute lung injury. Again, not due to volume overload, so diuretics are not indicated, but it's kind of like a flash pulmonary edema from inflammatory markers. Okay, similar picture to ARDS, but we can reverse it if we stop the transfusion. Okay, we give supportive respiratory care until all of those antibodies are out of their system. Metabolic acidosis. Okay, again, if that bank blood has hemolyzed a little bit, you can actually give them a high dose of potassium within that and cause hypercalcemia or hyperkalemia, which then leads to metabolic acidosis. And then hypothermia during transfusion, more so related to the transfusion reaction, but tachycardia, hypothermia is a thing. Okay, so it's just certain things you need to watch out for to see if you need to stop the transfusion or not. Hypothermia, okay, so the saturation of oxygen decreases with hypothermia. Okay. Mainly, not necessarily due to the affinity of the oxygen to the blood, to the hemoglobin, but basically your blood slows down. Your blood gets thicker. Okay, it's not going to move to those areas quick enough. Okay, so when you are cold, everything slows down, meaning your saturation slows down. Okay, that's why it's part of the lethal triad. You metabolic acidosis. You have a hypercoagulable state, coagulopathies, okay, your clotting factors are not doing what they're supposed to be doing, and then you're cold. Okay, you have those three things that leads to a death spiral in trauma and or critical care. Okay, these are the things that we are trying to prevent, which is why if you're in a trauma OR, it's going to be hot. A burn OR is going to be hot. Okay, if you ever get to go to a burn OR, make sure you're hydrated and you're eating beforehand because you will sweat your ass off. It's hot. Okay? We are trying to keep the patient's temperature up at the inconvenience of us. They're the most important thing. We try to keep their temperature up. That's what we can do, at least on the outside. And then anesthesia really helps with the coagulopathies and the metabolic acidosis during the case to try to fix those or prevent those. All right, wound complications. We already talked a little bit about this, hematomas, seromas. Okay? If they're small, they resolve spontaneously. If they're large, we may need to aspirate them or open them to wash them out and decompress them. We may be able to tack down within that seroma or hematoma that's been formed to try to prevent it, or we can make drains on positive suction to try to close down that space enough so that it scars down. Okay. Early fascial dehiscence, you have that salmon colored fluid coming out, that peritoneal fluid. Unrecognized fascial dehiscence or incisional hernias. Okay. Surgical site infections, always, like we already talked about, there's open, there's irrigate, we'll let it heal by secondary tension. Okay. Do not reclose these if you can. You most likely will not reclose them. Alright, compartment syndrome. Okay. Normally we see these associated with long bone fractures or crush injuries, electrical injuries. Okay. Basically, there is a abundance and increase of inflammation in very tight quarters. Okay. We can do fasciotomies pretty much everywhere on your extremities, even down to your fingers, toes, hands, feet. There's a lot of fasciotomy sites that we can do. Okay. If we need to open up those compartments to let the blood flow through to prevent critical limb ischemia. Okay. So again, pressure in those compartments causes impaired suction or perfusion, which then leads to ischemia, which then leads to necrosis. Okay. A lot of times it is a result of like vascular trauma, but again, like I said, it could be anything that has an extreme amount of inflammatory response that causes swelling in that area. Okay. Early symptom, like we talked about, peeing out of proportion. Early, if you've gotten down to loss of function in the distal pulses, that is a late finding, you're already behind the game. How we do fasciotomies is we have to excise through the skin in certain areas. Okay? And we have to go all the way through the fascia. And this is not just a tiny little nick. We go all, like say we're on the lower leg, okay? We have to go all the way up to the knee and all the way down to the ankle. We're opening both the anterior compartments, posterior compartments, the deep and superficial compartments of the gastroc. Okay? You have to release all compartments or else we've missed something. If we don't open those all the way, and say we've only done like a 5-inch incision instead of going all the way, there's still risk of that area above that's still within the contained fascia that still could put enough pressure on those veins or arteries and the neurovascular bundle to cause critical limb ischemia, and that what you've done is just really not enough. Okay? You need to allow that muscle to swell. And so when we're talking about the lower leg, right, you have the tibia and fibula, right? This is, let's say this is the top portion looking down at the left leg. Okay, so medial, you have the tibia. This is where we do one incision and we try to get the deep. We basically take the soleus off the back side of the tibia. We scrape that muscle completely off because your neurovascular bundle is in between the deep and anterior compartment. You have to get all the way deep. So we're basically scraping that muscle off the bone from the knee to the ankle. Okay? And then we release the posterior compartment, or superficial posterior. Okay? And then we don't have to necessarily scrape or do anything back here. We just release it all the way from the knee to the ankle. When we go laterally, okay, we go probably about 2 or 3 finger breaths down. We do an incision, 1 to 2 incision all the way down. We try to find this
demarcation.
Is the oh my god, brain fart. Basically, it's the fascia that separates the anterior and lateral compartments. There's a word for it. I will find out. It's in there. Sure. Intermuscular septum. I think that's it. That sounds right. Anyway, so we go and we find that septum, right? We find that fascia, and then we cut above it, Then we've got below it. If we don't find that intermuscular septum or intermuscular fascia, we cannot definitively say that we've got an anterior lateral compartment release. All right, abdominal compartment syndrome, pretty rare these days because we have a lot more preventative things that we can do. We can leave the belly open. We can have a wound vac within and over the intestines. That's called an aphthera. We can leave that open to allow for those bowels to swell. To get them through their acute inflammatory response phase. And then once they're able to kind of decrease that swelling, we can go back in and then close the belly. Okay? We can only truly diagnose an abdominal compartment syndrome if the patient is paralyzed. If they're not paralyzed, then just from even adequate pain control via either a drip or a fentanyl drip or whatever they're on, okay, they could still have the involuntary guarding, increasing that intra-abdominal pressure, causing a false high abdominal compartment pressure number. Okay, so they have to be paralyzed. We have to take away that ability for them to involuntarily contract their intra-abdominal muscles. If we miss it, or if we're really worried about it, we close, but we're like, maybe that wasn't the right idea. We're going to frequently, they're going to be in the ICU, and we're going to frequently check for acidosis with lactic acid. Okay, we're going to check, put a pulling in, and we're going to be looking at their urinary output. Okay, if any of those things happen, so increased lactate or decrease in urine output, we're most likely going to go back to the OR and reopen them. All right, decubitus ulcers, risk factors, people who are immobilized, not really moving, spinal cord injury patients, the inability to move themselves to find that position of comfort. Okay, you're going to start with your edema over the bony prominences. You're going to then end up with ulcerations. You can get down to exposed fat, bone, tendon, necrosis of these things. Okay, a lot of wound care is from decubitus ulcers, pressure sore ulcers. We need to give them adequate nutrition. We need to turn them if they can't turn themselves. We need to be padding those areas of high pressure points. There are special aerobeds that we can give them, okay, that actually turns them on a rotation. Okay, good skin hygiene, actually looking at the skin every single day, cleaning their skin, giving them a bath, daily skin inspections. Okay. And then a lot of times too is just making sure that like when you are helping the nurse, either clean them or change their bedding, that they're not on like a rolled piece of paper, like the bed chuck pads, or that there's no wires going behind them, or there's nothing, that just like a nice smooth sheet. Okay? Because anytime you have that roll, it'll put pressure on the skin that's not normal. And it can cause pressure points within there. Okay. If we see a pressure wound, we'll try to, if it is a abscess, if the pressure that's turned into an abscess, we'll be trying to drain it. Most of the time it doesn't turn into an abscess. We just have to go in and debride all of that necrotic tissue. We'll pack it. We'll maybe put them on antibiotics if it looks like it's cellulitic. Okay. But we have to get all that necrotic tissue out, or else it's going to continue down this pathway. Okay, so 4 stages. The first one is just red skin. Okay, non-blanching red skin. Stage 2 is you have that loss of dermis. Okay, it's going to have a open ulcer bed with either red or pink wound bed. Okay. Stage 3 is its full thickness. It can go all the way down to through the dermis, through the subacute fat. Okay, and then when you get to 4, it is down to exposed tendon, muscle, could be down to bone. Okay, if it's unstageable, it is something. So we don't really until we debride it, we don't know what stage it's at. Okay, it's got this thick eschar on it, or fibrous tissue on it, that we really have to take them back to the OR to scrape all that crap off, and then we can stage it depending on how deep it actually went. Okay. All right, post-operative fever workup. This is anybody with a post-op fever 101.5 or 38.6 Celsius above. Okay. These are not going to necessarily be your atelectasis or your post-op normal inflammatory fevers. Okay. You have to start looking at the wind, water, wounds. Again, atelectasis. I really won't see atelectasis with anything above 101.5. It can be right on the border, but if you're like 102.5, it's probably not atelectasis, it's probably already into the moment. Okay? Or something else, or anastomotic leak, or something else is going on. Water meaning UTIs, and then wounds, skin and soft tissue infection. What do? We get a chest x-ray, we get blood, urine, sputum cultures. Okay, we want to insect all of their, I know on the slide it only says IV, but you're checking for every single device we have on them. ET tube, their IVs, their, if they have a PICC line, if they have a central line, if they have a Folian, if they've drained. Okay, maybe that drain is clogged and is not actually helping with source control. Okay, we inspect every single device site that we have on them or in them. Okay. And then how we prevent it, we try to remove all of those devices as soon as humanly possible. Okay. Alright, so in most patients, the temperature elevation resolves without specific treatment. Like I said, post-op fevers. Okay? That's about 40% of all patients. We really hold off on doing any like cultures until like maybe day 2. Okay? Unless they look frankly septic. Right? All of their liver or renal labs are all screwed up. In terms of being associated with a likely bacterial infection, okay, out of these 6 things, so if you have preoperative trauma, a ASA class over 2, fever at onset of the second post-op day, your initial temperature of above 38.6, you're above that 101.5, you have a post-operative white blood cell count above 10, and a post-operative serum urine nitrogen of 15 or greater. If you have 3 or more, nearly 100% likely that you have a bacterial association with that fever. Okay? So that is a good thing to know when you're rounding in the hospital. Okay? ENT complications. This is again why we do really aggressive oral hygiene. You can get parodontitis. Okay. If we don't put them on humidified air, they can have nosebleeds if they're on like nasal cannula for a while. Sinusitis if they have like an NG tube in, or anything within their nose. If they had even a MPA, okay, with EMS, can translocate bacteria and cause sinusitis. And then if we give any medications that can actually cause hearing issues like vancomycin or any immunophlebotomides, it can cause ototoxicity. Okay. How to keep your patient alive on the surgery service. Round on the sickest patient first. You're not rounding on the floor first, you're running in the ICU first. If you're not in charge of the ICU or running on ICU, you go to the sickest patient first. Okay? If the nurse calls, you go see the patient. Don't just say, this is the 5th time you've called me, I'll come see them later. No, you get off your ass and you go see the patient, even if it's 3 a.m. Okay? What you're looking for is their DCS, are they altered? Okay, what's their vitals? Have you guys learned DCS yet? Yeah, okay, so when you're looking at DCS 15, right, if it's not 15, you have to let us know what EVM is, okay, so we can figure out where their disruption is. Okay, assess those ABCs. If they are, you know, they don't have a pulse, not breathing, you start, you know, call code blue, in CPR, ACLS stuff. Always consider that MIPE. Again, this is nothing you haven't heard before. Anaphylaxis, give, you know, EpiPen, dihydroamine, steroids. The biggest thing is always keep your senior resident and your staff surgeon informed, and never be the only one who knows. Okay? Don't be that person that tries to, like, not say something because you're afraid of getting in trouble. You're a student, you're a student level. If they don't know, they can't protect you. Okay? So, never be the only one who knows. Okay, nosocomial infections. These are just the percentages of the, you know, how frequently we see them. Surgically infections, about 36% of the time. C. diff 30. A CAUTI, or catheter-associated UTI, about 17. Central line infections, 19. A VAP, 7. Okay, ICU spiral death, almost done. So this is what I was trying to talk about, like that spiral. Once we get into the spiral of either a lethal triad spiral or multifunction spiral death, like the ICU spiral death is one of those that is extremely hard to correct if you're already in that spiral. Okay, if you have two or more following, so if you have temperature above that 101.5, tachycardia, tachypnea, leukocytosis, you have now met criteria to be in SIRS. Okay, now add on a source. Now you're in sepsis. Now you start looking at end organ failure. Now you're in septic shock. Okay, once you're in septic shock, the risk of death is very, very high. Okay, it's very hard to correct septic shock after you're already in this spiral. Okay, so we try to treat them while they're in SIRS, while they're in that, you know, acute phase. All right, we have a 71-year-old patient who undergoes surgery for colorectal cancer. Post-op, the patient developed an intra-abdominal abscess. Despite antibiotic therapy, the patient has persistent fever, develops hemoptysis and melena, in association with vertic skin rash. Laboratory tests reveal 70,000 platelets per microliter, prolonged prothrombin time, decreased fibrinogen. What is the appropriate treatment for this patient's suspected condition? What is she in? Potentially. I didn't give you any vitals, but what do you think she's in? With persistent fever, abdominal abscess.
Sepsis.
Probably sepsis. Okay. What do we do to treat her? What do you think? What's the next step? Who wants 1? 2? 3? 3, 4? 5? If you picked drain the abscess, you would be correct. Okay, we have to get source control. We have to try to prevent, okay, septic shock. Right? Her platelets being 70, that's okay. I only really care if it's below 20. Draining that abscess will fix this. Okay, we're not going to give her heparin because she's already bleeding. Don't give her heparin, she's already bleeding. Okay? Giving cryoprecipitate transfusions, what she needs is probably clotting factors. So cryo isn't the best one. We would rather do freeze-dried plasma, okay, or FFP. And oral antibiotics. She needs IV antibiotics, but not oral. Alright, does this make sense? Any questions? Okay.